Welcome to the Stanford Women's Health Vodcast series. I'm Dr. Sharon Hung, Director of Women's Health for the Primary Care and Population Health Department at Stanford. From debunking myths to exploring the latest research, we will delve into the world of women's health with leading experts in the field. Today, I have the honor of speaking to Dr. Allison Kurian. She's a professor of medicine in the Division of Oncology and Department of Epidemiology and Population Health at Stanford University. She focuses her research on cancer genetics and precision oncology. As director of the Stanford Women's Clinical Cancer Genetics Program, Dr. Kurian focuses her clinical practice on women at high risk for developing breast and gynecologic cancer. Dr. Kurian, thank you so much for being here today.
Thank you very much for having me. I'm happy to be on this episode.
I'm curious, what led you to the field of cancer genetics?
So it's a great question. And I always think many of us as doctors have sort of an origin story of how we got here, and really because it's such a calling as a profession and not just a job, right? So I think for me, I was always interested in a population level view of who gets sick and who doesn't. For some reason, that's how my mind always worked. So I was very interested in this question of why some people get a disease and other people don't. And once people get sick, why some get well and some don't. So I think in that question, there is a lot of meaning in terms of social justice, certainly, but also thinking about susceptibility to disease and recovery. And so because of that, I ended up doing a degree in epidemiology as well as my medical degree, and was always drawn to thinking about risk and prevention. And so when I went into oncology, it became something that drew me even more, was to think about cancer risk assessment and cancer prevention as ideally a way to improve outcomes in oncology, which often are not as good as we would like them to be. And I'll also share that I had a roommate at Stanford when I was an undergraduate who had an inherited genetic disease causing cancer risk. And while I never really set out to study this for that reason, I think these experiences certainly affect us.
Interesting. I find that very interesting, and I definitely want to talk about prevention and not just screening, because I think that does get lost in the conversation a lot of the time. So breast cancer, as we know, is the leading cause of cancer in women, and the famous statistic is that 1 in 8 women will be diagnosed in their lifetime. And while we've been seeing a reduction in breast cancer mortality due to improved screening and treatments, globally, we've been seeing an increase in breast cancer incidence. Could you talk about why we're seeing these trends?
Absolutely. I think we've been seeing that for quite a while. If you look at the data in the United States, we started collecting data on a population level about 50 years ago. In fact, it was just the 50th birthday of the United States SEER registry, which is how we collect cancer data. I also turned 50 last year, so we had, sort of fun. There was a SEER party and I got to attend, as did many of my colleagues, so it was fun. But I think we have about 50 years of really good population level data in the United States. And so what we've seen certainly for breast cancer is that there has been a rise in incidence throughout that time. There has also been a decline in mortality. And those things I think are related. I think part of the rise in incidence has been about screening. So around that time, we also began population level screening of doing mammograms on women, even if they weren't having any symptoms, with the goal of detecting cancer early. And so that, of course, boosts the numbers of cancers found in the earlier stages, and has also been correlated with a reduction in cancer mortality. Despite the controversies that we've heard of in the field, we do know that that's true. So I think that's part of it. I think the other part of it is risk factors. So we know that a number of breast cancer risk factors have been increasing over that 50-year interval. Many of them are lifestyle related. So things like on a population level, age at first childbirth, number of pregnancies, duration of time spent breastfeeding. All of these are things about the changes in women's lives over these intervals in terms of education and being in the workforce and many other things of that nature. There have also been other risk factors. So use of alcohol, that's increased in women during this period. Tobacco also has increased, although there's been sort of an up and down there, but we're still seeing the effects of that come through the population in terms of risk. And then the other things that can have a role are weight gain after menopause. That can also be a risk factor. And hormone replacement therapy can be a risk factor, which we'll also talk about. But so the cohort over the last 50 years, seeing the cohort effect of all these things, I think has contributed to this increase in breast cancer incidence, But also there's been the good news of this decline in mortality.
And you mentioned things like alcohol and smoking, and I think that's just so important to highlight for a second because I have so many patients that think that one glass of wine a day is safe. But according to the American Cancer Society, women who have one alcoholic drink a day have a 5 to 9% higher chance of developing breast cancer compared to women who don't drink at all. So in addition to telling them, probably to avoid alcohol, obviously avoid smoking, exercise, what are some other modifiable risk factors we can counsel patients on?
Yeah, I think it's so tricky, and I'm sure it feels unfair to a lot of people, right? Because years ago, everyone was told, oh, a glass of wine a day is good for your heart, right? And now we're baiting and switching. And as an epidemiologist, which I am in addition to an oncologist, I just try to say, look, the data are maturing, and our apologies that there can be inconsistency. It's because science is improving, right? And we're learning more. And so I think clearly now there are enough data to say that alcohol does appear to be a carcinogen. The American Society of Clinical Oncology came out and said that a few years ago, so that was a change. And when you look at the studies of women with breast cancer and alcohol, it does look as if when we're starting to get up into one drink a day, that risk does increase. And it's tricky to know how much is safe. For a while, we've said, if you are worried about it, keep it at 3 drinks a week or fewer. There's some hand waving there. I don't think there are really strong data. And of course, none would be fine. So that's always my statement there. For smoking, it should always be none. In terms of other things like weight gain, again, it's been tricky. There has been an association epidemiologically with weight gain in adulthood. It's tricky to say whether weight loss, if significant and sustained, actually reduces breast cancer risk. As we know, it's hard to keep weight off, and so there really haven't been good studies among a whole lot of people who've been able to do that. We'll have to see what happens now that we're seeing some pharmacologic interventions that are doing different things with weight loss. I think we don't know yet. And we think exercise is likely to be valuable. I always joke that no one's ever found out anything bad about exercise, much as some of us who are naturally sluggish might like it to. It does seem to be good for everything except maybe your joints, but nonetheless, I think it is likely good for everything, including your cancer risk.
Do you know if there's any information on whether certain diets or avoiding certain foods, etc., have helped decrease breast cancer incidence?
Yeah, that's such a challenge. And I think it's interesting. There were data earlier on in heart disease, right, about low-fat diets and things like that, and they really seemed compelling. And then when a lot of the famous investigators in the field tried to take that to cancer, it just didn't work as well. I think the data for cancer and diet are probably strongest for colorectal cancer with red meat. I think that for other types of cancer, it's been more difficult to make a clear correlation. I will say that as a cancer doctor, I most often see people coming in worried about 3 things. They are worried about red meat, dairy, and sugar. And I think it just shows you what people feel guilty about eating, right? So I hear that a lot in terms of thinking about breast cancer risk. And truly, we haven't seen a direct link to any of those things. Again, I'm not encouraging eating red meat. I think there are other reasons not to, but we haven't seen a strong link with breast cancer risk. I do think there's a bit of a urban legend, really, that sugar feeds cancer, right? So we've all kind of heard that. Again, I haven't seen any direct data on that front. I think there's a complicated relationship with diabetes and obesity, but I'm not sure it's sugar in the diet per se. And dairy, no, this is something that people worry about, but I don't know of any evidence. For a while, there was concern about soy in the diet. And so people were worried that eating soy in the diet could be associated with estrogenic compounds and a greater risk of developing breast cancer. There have been studies that have disproven that. So it is not an issue. And so we don't really think there's a specific diet that people need to adopt.
Okay, good to know. And so I'll probably keep drinking my dairy and sugar for now until there's stronger evidence.
I mean, moderation in all things, right?
Yes. And then what are some non-modifiable risk factors for breast cancer other than family history that we should keep in mind as we're assessing patients' risk?
It sounds silly, but sex and age, right? I mean, I know that everybody knows that, but obviously being female at birth. Males do get breast cancer. The average male has a risk of 1 in 1,000, where the average female a risk of 1 in 8 in this country. But just keep in mind, and age. Cancer is a disease of aging almost always. We can talk about exceptions, but it's all about the accumulation of gene mutations. And so one thing that I think is actually kind of important is sometimes I see older women in their late 70s who are incredibly fit and playing tennis every day, but saying, oh, I don't need a mammogram anymore. They told me I don't need one. Isn't that great that I'm not at risk anymore? And it's not that they're not at risk anymore, right? It's that a decision has been made that this person is not likely to have the life expectancy or the performance status. And in fact, when people are very fit in their 70s, I would think about, continuing to screen them. I would just say that. But that in terms of other risks that are non-modifiable, we talked a little bit about family history. We'll talk more. I think there are some mysterious but interesting risks like mammographic density, which we can discuss a bit, but again, not completely sure how that interacts with genetics, but is a risk factor. Then there are some weird ones like height, which I know sounds awfully strange, but many epidemiologic studies have shown that being taller is associated with breast cancer risk again and again. We don't know exactly what that means. It may have something to do with nutritional status and perhaps earlier menarche. So it's unclear, but that's been shown many times.
Okay. And I guess why don't we go ahead and talk about breast density, because now the FDA is requiring that by the fall of this year, all states will have to report dense breasts that are seen on mammogram. So for women who do have the mammogram showing either heterogeneously dense or extremely dense breasts, how do you talk to them about their cancer risk, assuming their average risk, no concerning family history, which we'll delve into later?
This is such a tough problem. I'm glad you brought it up. And we in California, I think, have been dealing with it for a long time. We were one of the earlier states to have a law saying that it was important to let patients know about this. I will say that in general, breast density, just to understand what it is basically a quality of how the breast looks on imaging. So sometimes patients think it's because their breasts feel lumpy on physical exam, but it's really not. It's a quality of the imaging. And the audience may all know this, but just so we're all on the same page, that typically, of course, we like for a mammogram, an x-ray of the breast, to have a nice dark gray color because cancer usually looks white. And with dense breasts on mammogram, what happens is that the background looks very white. And thus, as you can imagine, it's hard to see a tumor showing up white amidst that background. I always joke that it's like a polar bear in a snowstorm. Stupid joke, but it is sort of that problem, right? That you're trying to find something that's hard to see because of the background. So number one challenge with mammographic density is it makes it harder to see things on our main screening test. But there's another issue, which is that independently, it does seem to be associated with an increase in risk. And there's a lot of question about why and what that really is that's being measured. And I think it's not fully understood. We know that there is a genetic component. So some studies have been done beginning to tease apart genetic, usually single nucleotide polymorphisms that are associated with an increase in the risk of breast density. We know that it's heritable, that density tends to run in families. And we also know that it's hormonally sensitive. So it's very, very typical in young women, women in their 30s for sure, and in their 40s, to have dense breast tissue on a mammogram. Usually as we go through menopause, the density becomes less, and that's why mammograms work better for us typically as we age. But there is a portion of the population where it never really gets less dense. And so those are the people where we worry about higher risk of breast cancer, but also higher risk of it not being found on a mammogram. And so this is where it gets tricky, because while we have a law saying that you have to tell people if they have dense breast tissue, it's a bit of an unfunded mandate, as primary care physicians, I'm sure, know. Because we have this saying that, okay, you have to tell the patient that the mammogram may not work so well for her, but then what are you supposed to do, right? And I think there are often statements, go talk to your primary care doctor, right? So then what, right? So I think it's always tricky, and this is where we get into breast cancer risk assessment. We can talk about that. Often my first step would be to try to find out if this person has other risk factors that would prompt an evaluation. But what if they don't? What if you don't find anything else? I think there are a number of potential other things you can add. Breast MRI sometimes will be added, rarely though in the absence of other risk factors. Usually it will not be covered by insurance in the absence of another cause of increased risk. I will say I think there are two other types of imaging tests, and here again, my radiology colleagues could tell us more, but just thinking about it, there are sort of two other tests that we can add when someone is not super high risk. One of them is whole breast screening ultrasound, and the other is contrast-enhanced mammography. And so for a while, screening whole breast ultrasound is sort of what many of us were doing. I will say that there seems to have been a trend toward feeling that contrast-enhanced mammography with an IV may be better. Again, I haven't seen that catching on so widely, but that is where I think many of our radiology colleagues are going.
I see. Thank you for bringing that up. I have to say, I've read about it. I have never personally ordered a contrast enhancing mammogram. I know we do kind of 3D tomosynthesis.
Yep.
Here's our standard of care at Stanford. So when would you consider contrast enhanced mammography?
So I actually, again, this is relatively breaking news. I was educated about this by our chief of breast radiology here at Stanford about a month ago, really saying that they often prefer the contrast-enhanced mammography, and I think we're all learning. But particularly if we're thinking about a patient who has dense breast tissue and you're trying to decide, maybe she had dense breast tissue last year, and you're thinking ahead and saying, should I order her mammogram and also a screening breast ultrasound, or maybe I should just order a mammogram contrast enhanced. So I will say, I think that's emerging. That's something that is not fully routine, but the American College of Radiology does approve both contrast enhanced mammogram and ultrasound as potential supplemental screening tests for women with dense breast tissue. So I bring that up.
Okay, great. Yes. And so, as you mentioned, I know the American College of Radiology recommends ultrasound as a supplemental screening tool for average to intermediate risk.
That's right.
And USPSTF and ACOG, American College of Gynecology, state that there's still insufficient evidence whether the benefits outweigh the harms. Some studies have shown increased false positives, increased recall rates when we add ultrasound. Do you have any, because half of the population, almost half, right, have dense breast. Do you have any suggestions on who ultrasound screening might be most beneficial for?
So I think this is always tricky. I would always advise a formal risk assessment. So I think it comes down to thinking about other risk factors. Often this might be an opportunity to take a good family history and determine whether this person might need genetic testing. And then maybe you learn something else that pushes you toward breast MRI, and you're not so much thinking about those two things. Otherwise, I think it comes down to typically a discussion with your patient. And like so many things, is a bit of a personality test, right? So how does this person feel about risk? Is this somebody who would prefer to have a false positive that might cause them to have a callback or an extra biopsy rather than being worried about missing something, right? And I think this is very much shared decision-making and all of those questions. But I would always say standard risk assessment first to make sure you're not missing something else that should push you toward a higher risk screening direction.
Yes, I agree. There's a lot of shared decision-making that goes on when we think about breast cancer screening, and it's not just mammography every 1 or 2 years is something that fits everyone. And you mentioned risk assessment a couple of times. So in addition to asking about the things we've already talked about, is there a specific calculator you would use, such as the BCSC score, when you're doing your risk assessment?
So I think it's a great question. And again, I know there was a famous statistician, I'm not sure who said that all models are wrong, but some are useful, right? So again, excuse my sense of humor sometimes. Make too many jokes, but at any rate, so I think there's something to be said for that no model is perfect. And so I always want to be really careful with a patient running a model, because sometimes she can feel like there's a number stamped on her forehead. So I always want to be careful about false precision. Sometimes I've seen patients come in and say, I was seen and they told me that my breast cancer risk is 26.43. And so there's absolutely no way to have that level of precision, right? No model is that good. And so you just want to make sure people don't feel as if they've been given, a fate and it's on them, and, this number is like their future. So I always advocate that if you're going to use a risk assessment tool, you talk to people in terms of ranges and in terms of the fact that none of these models is perfect. All of them are just to get kind of a ballpark risk. So that would be my initial caution with using any of the models. None of these models is fantastic. They have been usually measured for discrimination, which is their ability to predict between a person who's going to get cancer versus not. So, which person is going to or not. And the most famous one, which is the Gale model, is about as good as flipping a coin. So its discrimination is 0.56, where flipping a coin is 0.50. So it's not that it's totally worthless, but you just have to take it with a grain of salt. Probably the one that is best among the ones that are widely used is called the IBIS model, IBIS. It's also known as Tyrer-Cuzick, because those are the two people who invented it. But IBIS, you can Google it. It's freely available. The reason why that's a better model is it lets you put in more risk factors, and it lets you put in family history with more detail, and it lets you put in a genetic mutation and also breast density. So if one is going to use a model, I would vote for IBIS, but I would always be careful to present these things in terms of ranges and let patients know that it's not absolute.
I see. That's good to keep in mind when we're running these models and discussing that with patients. So speaking of some of those numbers, one of the indications for annual MRI screening is if there's a greater than 20% lifetime risk as calculated by one of these models. In addition to people with BRCA mutations, first-degree relatives of BRCA carriers, and those with an elevated lifetime risk, who else should we be talking to about an annual MRI for screening?
I think it's such a great question, and I'm always interested when we think about that threshold, because of course that threshold was created by a committee, and I've been on some of those committees, so it's partly my fault. But really what it is an attempt to say, when you hit double the average, we should consider this. That's where that 20% comes from, right? And so with the average woman having a risk of about 10 to 12%, the argument has been sort of 20 to 25%. It starts to get to be worth it to consider a test that might be more likely to give you false positives because the positive predictive value is higher. And I'll just say again, it is arbitrary. If you look at other countries, usually those with National Health Service programs, the UK, Australia, all of them have picked 30 to 36% as their threshold. So it is totally arbitrary. It's about what society is willing to pay for. And they have picked threefold risk. We have picked twofold risk. So just to put that out there, that is where that comes from. So I always think of it as a guideline. I think of it as sort of saying, at what point are we looking at somebody who has double the average risk? I wouldn't get too hung up on 20%. I would sort of be thinking about double the average. And so things that will get you there are certainly having a family history. So if you see a patient with 2 first-degree relatives, you can run any model you want. That will be enough to get them to double the average risk. And then other things like that often will play a role. I think the genetics are always a key point. So I will talk a little bit if useful about genetic testing, but just to answer your current question, any of the genes we know to be associated with breast cancer will give you at least double the average risk. So that's that piece of it. There are various findings on biopsy that are not breast cancer, but will give you double the average risk. Anything with the word atypia in it, so atypical ductal hyperplasia, atypical lobular hyperplasia, anything with atypia means call a surgeon to evaluate is my rule, but it also doubles the risk. And there are a few others, lobular carcinoma in situ, those kinds of things all get you into that category. A few other exposures, the primary one being radiation to the chest at a young age. So people will see that around here. We at Stanford are a major world referral center for Hodgkin's disease. And of course, that happens in the adolescent years. And the most common site is the left neck. So people get radiated and it often gets the chest area, and those patients have a high risk later on. But those are the main risk groups that get you to that double the average risk.
I see. And then and another question about MRI, should we be using MRI screening for breast cancer survivors or just a subset of them?
You ask all the good questions. Yeah, so I will say this is where guidelines disagree. And it's always frustrating when they do that. I, full disclosure, help with guidelines for National Comprehensive Cancer Network and the American Society of Clinical Oncology. And then there are radiology-specific guidelines, American College of Radiology, and of course, primary care guidelines like USPSTF, right? So they're all coming from a slightly different perspective. I will say that American College of Radiology would say that breast cancer survivors, very reasonable to get an MRI, certainly on anybody who had breast cancer under age 50, they would support that. And I think that's reasonable myself, partly because it's a bit weird to have breast cancer under age 50, and people who have it once may have a higher risk of having it again, right? So MRI is useful there. And those patients are more likely to have dense breast tissue because they're young. So I think all of that is reasonable. I would also always think about doing a risk assessment. Do you have reason to think this person's risk is double the average? Typically, models like IBIS and GALE are not validated for people who've had breast cancer. So we don't usually run them because they don't really work there and they haven't been validated. But again, it's this question of, does this person have multiple relatives? Was she diagnosed young? All of those kinds of things. And certainly if she has a genetic mutation, you're going to be doing MRI. The other thing I always think about in patients who've had breast cancer, was the breast cancer missed by the initial mammogram? Right? Because if that's the case, I'm not going to trust the mammogram alone again. I won't throw it out, but I will want to do something more than that. So that's one of them. The other is lobular breast cancer, famously hard to see on mammogram, easier to see on MRI. So that would be my 2 cents.
I see. And then as we're talking about these different modalities for screening, I'm just curious how kind of the racial disparities that we're seeing kind of plays a role in risk assessment. Black women, for example, have some of the highest mortality rates for breast cancer in the Bay Area. We've been seeing a rise in breast cancer cases in Asian women.
That's right.
Can you talk about how we should keep this in mind and how that might affect screening?
Yeah, I'm so glad you brought that up. I think it's so important. I mean, there are huge disparities in breast cancer mortality still. And one thing that this audience may not know or may know is that if you look back to that time when we first started keeping track in the early 70s, there actually were no disparities in mortality between Black and white women because they all did poorly from breast cancer. And now, unfortunately, what's happened is that mortality has gone way down for white women, but not for Black women. So what it says is that this is all about progress being made, but not being equitably distributed to everybody, right? So I think that's a real lesson, and clearly that it's about structural racism and access issues and many other things. So let me just say that the data show that. In terms of what to do about it, I think there have been guidelines, including some related to USPSTF based on CISNET modeling, that have said probably with Black women, it's important to start at age 40 and screen every other year. So this is a group that has a higher mortality rate at a younger age. And so we really should probably be starting younger and screening yearly for them. And I think, again, low threshold to think about supplemental imaging if a patient has dense breast tissue or other features there. And I think thinking more carefully for that group of patients who has a higher risk and, of course, traditionally has been underserved in so many ways. So I would keep that in mind for sure. I think in terms of Asian women, you're absolutely right. They're the group in which breast cancer is rising the fastest, unfortunately. Why is that? I don't know. Thought has been about changes in lifestyle, but in fact, we do see it rising for whatever reason. And I will say something that is rather interesting is, in fact, higher breast density seems to be more common in women of Asian ancestry. I do not know why. There have been thoughts about body habitus and maybe less fatty composition as opposed to density and things like that in terms of body size, but nobody really knows. And it's just something that we see, is that there is a difference. So I would be aware of that. And again, would be on the lookout for Asian women who have dense breast tissue. I would again be thinking carefully about, should we be doing screening ultrasound? Should we be considering contrast enhanced mammography? Should we be thinking about any reasons that an MRI might be appropriate here?
Yeah, I feel like I have so many follow-up questions to what you said, and I feel like this is an hour topic in and of itself. But I guess to continue on just the discussion on Black women, I've also read that they tend to have more triple negative disease, which is often missed on mammogram, right? And so does the IBIS score kind of take that into account? Because, in terms like race into account, and I'm just wondering how, when we would kind of pull the trigger on doing an MRI screen for someone who has, race as an additional risk factor.
Great question. And no, those models really don't take race into account. I will say IBIS comes from the United Kingdom. And so again, a primarily white Northern European population, getting more diverse, but it is coming from that place. And so I think it's important to keep that in mind. We actually did a study where we validated its performance across racial and ethnic groups a few years ago using a large cohort from the Women's Health Initiative. So I think it's reasonable. We found in a large data set that it did work reasonably well across all racial and ethnic groups. So I think it's good, but I would just keep that in mind coming from there. And I think it's tricky when you look at the absolute risks. We also did a study of that a few years ago, where we looked in the California Cancer Registry, which is a component of the SEER registry, and said, if you're a woman living in California, what is your lifetime risk of getting different kinds of cancer? And so what we found was that if you were a Black woman in California, your lifetime risk of getting triple negative breast cancer, the bad kind, was about 2.1%, whereas if you were a white woman, it was about 1.1%. If you were an Asian woman, I believe it was about 0.8, 0.9% for that triple negative breast cancer. So I don't know why it's different. The genetics have not been very simple. It hasn't just been, one clear thing. I will say that when people have looked at this in areas of Africa, West Africa in particular, they do still see those trends of more triple negative breast cancer. So there may be something genetic going on, but it is what we see. I will just say that when we've been thinking about, all right, our usual threshold for MRI is somewhere about around 20% lifetime risk, right? Here we're talking about a risk in range of 2% absolute. So most of the time people would not be doing MRI for that, for Black women just because of being Black. But again, I would be very careful to look at other risk factors. Is there anything in the family history? Are there other relatives with breast cancer? Are there relatives with other cancers that might be suspicious for genetic risk in the family? So just thinking about those things would also be important.
I had been reviewing some just data on how useful ultrasound screening was a supplemental tool, and it seemed like a lot of the studies showing the most benefit was in populations in Asia. Do you agree with that based on the research you've done?
So I would have to look at that carefully, but I suspect that is about the underlying higher breast density. Several studies have shown that, and so I think probably the mammogram is just performing more poorly. And so the ultrasound is contributing relatively more than in populations where the average breast density is lower.
Okay. And it's also timely we're having the discussion since in primary care, we tend to follow the USPSTF, and they recently changed their guidelines to start screening at 40. Is part of the reason because of the racial disparities we're seeing, or are there other reasons, in your opinion, why we're shifting towards screening everyone at 40, which I know other organizations were already recommending?
Yes, it's hard as a breast cancer doctor because for us, we see all the missed cases, right?
Yeah.
So you guys in primary care see the false positives, so we see the false negatives, right? And while we all are data-based, it's hard because those are the things that kind of burn themselves into your memory, right? And I'm sure for you as well, in terms of people getting more screening than they really needed, we see people who got less. So I think it's a very difficult challenge in terms of kind of where we sit with this issue. Hard not to be a little bit emotional about it as doctors. I think in terms of where people were coming from, I think in general, there's concern about rising rates of cancer among young people. So we talked about this issue with rising rates in general among young women, but also among people of Asian ancestry, and the concerns about higher mortality among Black women. And so I think all of those things played a role. There has been sort of long-term speculation about how much harm is it really to have a callback, right? And so it's these questions. I think back in 2009, there were guidelines that said, well, it is so burdensome for a woman to have a callback or a false positive that we shouldn't advise it. Women often said, I can really make up my own mind, thank you, about whether this is so burdensome for me. And so I think it's just a tricky thing, but I think the needle is moving partly because of the rise in risk among younger patients. And not just for breast, but we certainly see that for other cancers like colon, right? So I think it's something that is in the public consciousness at present.
Yeah. Okay. And then I wanted to jump into genetic testing before you run out of time. And one update that I saw was the American Society of Clinical Oncology gave a recent new recommendation that patients less than 65 years old diagnosed with stage 1 to 3 breast cancer should be offered BRCA1 and 2 testing. Can you talk about the reasoning behind this update?
Yes, and full disclosure, I was on that committee. So that's partly my fault.
Committee, and you've done every study, I think, is my takeaway.
Not at all. Not at all. I don't mean it that way at
I
all.
love it. You're the perfect person to talk to about all these issues.
I'm just old at this point. So that's what's been going on. But no, so it's a privilege. So I think that has been a few different things. One of them has been this remarkable thing over the last decade, where for the first time we have a germline targeted therapy for breast cancer. I mean, it's really quite amazing. But these are the PARP inhibitors, the poly-ADP ribose polymerase inhibitors, which are very effective in cancers caused by BRCA1 or BRCA2. And that's not just breast, but other cancers as well. And increasing evidence also in cancers caused by another gene, PALB2. So the idea here is you really don't want to miss patients who could benefit, because for patients with early stage breast cancer, giving one of those drugs after their standard treatment significantly improves overall survival. So you don't want to miss that opportunity to save lives, basically. And so that's the rationale for saying we don't want to miss cases. Studies have been done to try to understand the prevalence of mutations in BRCA1 and 2 and other genes by age of breast cancer patients. We actually did one in the Women's Health Initiative a few years ago that looked at this and found that for women diagnosed under the age of 65, the chance of having a BRCA1 or BRCA2 mutation is about 2.5%. The reason that number stuck in people's heads is it happens to be the same as the chance of having a BRCA mutation if you have Ashkenazi Jewish ancestry. And that's come up because people of Ashkenazi Jewish ancestry, it's generally considered go ahead and test because that 2.5% rate is high enough. And so seeing that that's actually the same prevalence as women who get breast cancer under 65 has been a powerful argument in terms of maybe we should offer testing for them too. There were other studies, one of them coming out of a large clinical network at the Mayo Clinic in Minnesota, that looked at this and estimated that the best threshold for finding people with genetic mutations and not having to test more people than really indicated was this cutoff of 65 and younger. Now, let me say that that does mean that we are going to be testing roughly 80% of all breast cancer patients if we observe that guideline. So it's a lot, but I think it's generally warranted by the evidence.
I see. Yes, it seemed like a lot more people would be tested, since I feel like most of my recent diagnoses have also been less than 65.
Mm-hmm.
So my follow-up question would be, do you feel like PCPs should be comfortable ordering BRCA1 and 2 testing, or should we still leave this up to the guidance of a genetic counselor?
You are asking all the good questions. I wish I knew the answers. So in one of my jobs, one of them is to lead our women's clinical cancer genetics program at Stanford, which is a great privilege. And we now have 11 genetic counselors in our hiring who are cancer genetics focused. And I started together with Jim Ford, who began the whole cancer genetics program and is our director for the whole thing. I started back in 2002. We had, I think, 1.5 genetic counselors, and we saw patients like, half a day a week. We now see patients every day and growing. So it is getting bigger and bigger, and that's true around the country as we realize that genetics is so crucial to really precision medicine. I would say that I think it's a little bit tricky in terms of who orders the pretest, because often we want to test genes beyond just BRCA1 and 2, and typically insurance will cover it only once. So the concern is about sending a test that might be too narrow. Of course, if you try to just test everything, then you may get weird results back that are hard to interpret. So I would say stay tuned, which is a stupid answer, but we're all trying to figure out how to do it. I think usually when it's a primary care situation, often it would be a question of testing somebody who maybe didn't have an active cancer diagnosis. And so in that setting, I would say often people might be able to wait and could be referred. If it's a newly diagnosed cancer patient, often that person is in the hands of oncology or surgery, and we're sort of negotiating with them what should happen. And soon I think we will have people being encouraged to test on their own. And at some institutions, we already have that, but with good genetic support. I think, what about a primary care scenario where you have somebody who had breast cancer years ago, but is now fine? In general, I would still probably refer that person to genetic counseling, because I think, again, it's not an emergency situation. And usually it would be a good idea because they might find things in the personal or family history that would make them want to add specific genes on to be tested. But it's a very dynamic area, moving quickly.
Yeah, I have heard that rumor that genetic testing can only be done once. So that's good to keep in mind so that
Just
we
insurance.
yeah. I
Yeah.
guess I'm on a follow-up to that. I'm just wondering because we're constantly learning about new mutations, right? So
Mm-hmm.
what do you do about the patient who sounds very high risk? Their genetic testing was negative, I don't know, X amount of years ago. Shouldn't they be retested at some point?
They absolutely should. And so, at least in our practice, and I think in most of them, we always say to patients who test negative, please check in. And we wish we had a way to constantly monitor everyone we've tested. We see about 3,000 patients a year at Stanford in our group. And so there's no way we can do that actively. AI, maybe when AI can jump in and do that, but we're not there yet. But so we actually suggest that patients send us a My Health message or call us once. We usually say once every 2 to 3 years. That's about when we've been seeing incremental jumps in the technology. And generally, when there has been a jump like that, insurance has covered it. So for example, years ago, we would do just sequencing of genes. Then we got into an ability to do large comprehensive rearrangement testing, so a different technique for looking at them. And that then was covered. So I think as new technologies come in that let us learn more, for people who tested negative, usually they can be covered to test again. It's just if, for example, your patient got tested only for BRCA1 and 2, but really they needed, an 80 gene panel, that might not be covered without a change in the technology.
Right. Okay. That's very reassuring because I feel like I have a lot of patients who the maternal history is very concerning and they say they were tested negative X amount of years ago, but I'm glad I can kind of encourage them perhaps to get re-evaluated.
So I'm glad you brought that up. And I would always just put in a plug for the paternal history too.
Oh, yes. Yeah.
Of course, you know that, but always just to remind people that, breast cancer risk comes just as much from the dad's side.
Yes, absolutely. And to follow up on that, can you remind us of, what aspects of the family history or personal history would warrant further genetic evaluation?
So it's such a great question. And I think, again, it's just asking about cancer history in the family. From a breast cancer perspective, I always think, in general, we expect to see 1 in 8 women with breast cancer. Ask about cancer in the family. And if it's looking like more than 1 in 8 women in that family, that's not typical, right? So just think of it that way, is sort of how I try to think about it. And you don't necessarily have to draw everything out and all of that. But, you have 2 or 3 cases in a family, that's probably more than 1 in 8 on average. I would refer that patient. That would be how I would think about it. I think anybody who herself had breast cancer now, right, under 65, good enough. What about over 65? I think then that could be considered as a referral. Certainly I would ask if she has other relatives with cancer, that might be a good reason. If she has children who are interested, you might refer her. And in general, it's always better to test the person who had cancer just because they're more likely to have the mutation than someone in the family who didn't have cancer. So that's something to think about, although we can get into that a little bit. But I would say other things in the family history, where sometimes a relative with cancer may not be alive anymore, but the kind of things that get our attention traditionally would be ovarian, pancreatic, prostate, metastatic prostate in particular, male breast. Male breast cancer is sort of a no-brainer. If you find a male breast cancer, that person gets referred for testing. Sarcoma, tends to be a red flag. So I just bring up a few.
Okay, thank you. And so anyone with, I think we often think about breast and ovarian as hereditary breast cancer, but really anyone with even just a family history of metastatic prostate cancer or just one person with pancreatic cancer should all be encouraged to get genetic testing as well.
So I think that's a great question of sort of how much family history do you need, right? I think, if you have one, great aunt with pancreatic cancer at 90, does that count, right? It gets a little bit more distant. I think if it's younger, if you have more than one case of pancreatic, for sure. What about metastatic prostate? Metastatic prostate is always a little bit of a red flag. It's just more common to find genetic mutations in men who died of prostate cancer as opposed to men who just got prostate cancer and didn't die of it. There's evidence that it tends to be more aggressive. So I think if there's a first-degree relative, so you have a patient and her dad died of prostate cancer, particularly if he died young, like under 70, I would think about that as a potential reason to refer.
Okay. And I know you mentioned that, and I know it's always optimal to test the affected family member who had malignancy. And I'm sorry, this is a very silly question, but how is genetic testing different if, the affected individual can't be tested? Like if my patient had family members that are affected, but they're either, estranged or far away, would you not still do this exact same gene panel on them? I'm just curious how it's different and less optimal.
Great question. It's not a silly question. It's very thoughtful. And I would say that you would do exactly the same gene panel, and a positive means the same thing, right? So you test your patient and you find a BRCA1 mutation. I really don't care about her family history anymore, right? I just care that I know what this gene is and I know what it does. I think the challenge in such a patient is if she tests negative. So let's say your patient has tested negative. You still have all this family history. You don't know what caused it. How should we take care of her? So for example, let's say your patient had a mother and an aunt who both had breast cancer in their 40s. Neither of them have tested. Maybe they're estranged, who knows? But now your patient is tested negative. Can we say that her risk is average? We can't, because we still have this family history of 2 relatives with early breast cancer, and we don't know what caused it. Now, what if your patient has tested negative and she's able to get her mom to test and her mom tests positive for BRCA1? Now your patient's negative result means something because you have identified the cause of her family history and you have proven that she didn't inherit it. So in that case, that would be what we call a true negative. You've found the genetic cause. You've proven that your patient did not inherit the genetic cause. Great news for your patient. She's at average risk, and she can largely not think about that part of her family history anymore. But if those relatives were never tested, we don't know. It could be that there was some other gene running through the family that I'm not smart enough to find in 2024, right? And so then if that's the case, and if I don't know what caused the relative's cancers, I still have to treat that patient like a high-risk woman, which means that I would have to do MRI screening based on family history and other things.
I see. Thank you for putting it into that situation. That now I have a better understanding.
It's confusing. Yeah, it's confusing. But this is, so let me just say, this is what I've learned in 20 years, 22 years now of genetic counselors being nice to me and teaching me. I always joke that I'm a fraud in terms of genetics. I do not have a genetics degree. I have, internal medicine residency and medical oncology fellowship, and I have an epidemiology master's degree. But I've just been hanging out with genetic counselors for 22 years, and I've learned a lot. So.
Well, I'm glad I got to hang out with you today. And
they're much smarter than I am. They're much smarter than I am.
We've talked a lot about BRCA testing, and I listened to some of your other lectures, which you mentioned things like PAL-B2, P10. I was just wanted to kind of ask you more about some of the moderate to high susceptibility genes that you think a primary care provider should at least kind of have heard of.
Absolutely. Yes. So I think there's basically a list, and I'm happy to sort of share. Probably the best guidelines in terms of a gene list would be either National Comprehensive Cancer Network, or there are new guidelines from the American Society of Clinical Oncology that did their best to sort of say, these are the genes to test. It's not perfect, but they just came out last week, and so it's something to look at. But I will say that in general, we think that there are about 7 high-risk breast cancer genes. I can name them, although it's sort of alphabet soup, but I'm happy to do that if helpful, and about 6 moderate risk genes. And so it's that list that it's sort of useful to know what they are. And I think kind of the high-risk ones, just to go through, are BRCA1 and BRCA2. PAL-B2, which stands for partner and localizer of BRCA2. It's a very similar gene function to BRCA2. So I think of it as kind of almost BRCA3. That's the other important one there. Then there are really rare but meaningful syndromes, TP53 that causes Leaf-Raumanis syndrome, P10 that causes Cowden syndrome, STK11 that causes Peutz-Jeghers syndrome, CDH1, hereditary diffuse gastric cancer syndrome, and those are the high-risk breast cancer genes. Again, there will be no quiz, nobody has to be able to recite them, but those are the high-risk breast cancer genes. All of them give risks that are in range of 50% lifetime or higher. All of them carry the recommendation to discuss the option of preventive mastectomy not to recommend it, but to discuss the option. So just worth knowing those. Again, I will not name all of the lower risk ones, the moderate risk ones, but the ones that I think it's useful for people to have heard of are ATM and Check2. We always joke that it sounds like they both sound like money, and unfortunately, neither of them give you money. But these are the stupid jokes we make in cancer genetics. Forgive me. But anyway, so ATM and Check2 are important because they're fairly common. So they are found in, Check2 is present in probably about 1 to 2% of people with white Northern European ancestry. It's pretty common, particularly Central Europe, so Germany, France, Czechoslovakia, anywhere like that, which, there are a lot of people around who have some of that ancestry. And it accounts for, for people with breast cancer, it accounts for probably 1 to 2% of breast cancer in white women. So it's a pretty common gene mutation. It's worth knowing about. That's Check2. ATM is relatively common across races and ethnicities. We think it could be seen in as much as 0.5% of the population, and again, about 1% of breast cancer patients. So both of these are things you will see in primary care because they come up. They both give about a 20 to 40% lifetime risk of breast cancer, so enough to do screening breast MRI, generally not enough to discuss the option of preventive mastectomy, although that varies. And each of them have some other cancer risks. So I would just want people to have heard of ATM and Check2, as well as PALB2, BRCA1 and 2, and a few others.
And so you said all of them we would consider MRI screening, and then what age would you start?
Yeah, so it varies a little bit by risk. So for the highest risk genes like BRCA1 and 2 and TP53, we start about 25. We start young, and that's because the cancers can happen young. When we get into the moderate risk genes, so like ATM and Check2, we start at about 40 there with MRI. We sometimes can start a little bit younger. We might start at sort of 30 to 35. We start with mammogram at 40. Sometimes we'll do MRI a little bit younger, but sometimes we'll do it sort of around typical starting age. So I would say mid-30s to 40s for the moderate risk genes.
Okay. And then what are your thoughts on the direct-to-consumer gene testing panels?
Again, all sorts of good questions to keep us on their toes. So I think, there are different kinds of DTC labs. And what I will say is that a kind of lab that I think many of us have favored recently are called hybrid labs. And those are labs where typically there is an option for people to self-initiate testing, but more commonly it might be that it would be with the assistance of a clinician. And there are a few of them that are well known for being very good in terms of the quality. And I'll mention a few by name that I think are very good. One of them is a lab called Color, and people may know that because it did a lot of COVID testing during the pandemic, but they also are a very good hybrid laboratory that enables what I would describe as very effective service to patients and family members, but with good involvement of clinicians as well, and ensure that any positive result is disclosed by a genetic counselor. And so just generally is a very good lab. Another one like that is called Invitae. Again, not meaning to say anything about particular labs, but I just bring these up because I think they do a very good job. I think there are others, and I won't get into details there, but where it is less helpful. And so sometimes there are labs that I guess I'll describe as really offering what's almost sort of recreational genetic testing. So things like, oh, where did your ancestors come from? Can you curl your tongue? All those sort of things that I think are kind of like party tricks, right? But so the challenge there is that sometimes some of those labs have other things kind of thrown in that might be important. And I'm always hesitant because I worry that, for example, some of those have had the 3 common mutations in BRCA1 and 2 among people of Ashkenazi Jewish descent. And people who get that may not know that, in fact, this is not all just about curling your tongue and where your ancestors came from. There are actually some serious things here. And so I always just want to make sure that any lab is going to make it very clear what we're dealing with. And so what I like about the hybrid labs that I mentioned is that they are very clearly making the point that this is medical grade testing. These are important. They need to be handled with the help of medical experts.
Yeah, I agree. It's so important to have a genetic counselor also help interpret those tests, because otherwise they come to me and ask, and most of the time I have no idea.
Yeah, as I said, genetic counselors have fished me out of trouble for 20 years. So
Any tips on what I should do if a patient pursues that test, comes back to me, and they're positive for variants of uncertain significance?
I love it because again, all the hard challenges. So here's what I'll say. I think it's actually less common that you're going to see that on a direct to consumer test because a lot of them don't do full sequencing. A lot of them are doing single nucleotide polymorphisms that just show little things like that. I think often we see variants of uncertain significance on good clinical grade testing. And so just to kind of get into what that is, basically, whenever we sequence a gene, either we're going to see something that is considered a normal sequence and in line with the normal accepted, standard sequence of the gene, or we are going to see something that is a fairly obvious mutation. And usually it's a chain termination. It's something that causes, premature stop and the protein clearly isn't made. That's a clear mutation. Variants of uncertain significance are something in between. Often it may be a very subtle change. It may be a single nucleotide change that we're not even sure if it affects the amino acid or not. It may be in basically a non-coding part of the gene, right? So we're not even sure whether that plays a role, but maybe we haven't seen that specific change enough to be able to assign it. And so let me say that a challenge here is where the normal sequence came from initially. And so again, because of issues of inequities in our societies, unfortunately, a lot of these genes were originally sequenced only in people of white Northern European ancestry. And so the normal sequence came from this very narrow group, right? And so as we sequence more and more people, you can imagine that the people who are more likely to get variants of uncertain significance are people from other ancestries who have not been sequenced as much, who maybe were not part of the original definition of normal, and maybe through various access inequities have not gotten sequenced so much overall. And what I'm trying to say is that the burden of VUS falls unequally, right? And particularly in people who are more likely to have been burdened by various health disparities. So I think that can be a real challenge. What I will say is that the great majority of variants of uncertain significance ultimately get reassigned to normal. The estimate has been 75 to 90% are reassigned to, that's just nothing. Usually that's normal for that population. So, just something that we see a lot when we sequence a lot of people of fill in the blank of what that ethnic group or population is. About 10 to 25% will get reassigned to harmful or upgraded, as we call them. What happens then? So basically, what happens with a variant of uncertain significance is whoever ordered it, whatever clinician ordered it, will get notified by the laboratory who reported it out when there is a change. Laboratories try very hard to reclassify these things as quickly as possible, because as you can imagine, they drive people nuts. And so there is very active, good, efforts to do that. And so it's important as an ordering clinician to keep your eye out. And if in fact there is a notification, that's important and it needs to get communicated. This is something where genetic counselors can help. Our group is happy to help and others like us in terms of that. But I would just say that follow-up is really important. Sometimes patients might come to us with a VUS ordered by somebody else, and they might say, this person ordered my test, but they were in New York and now I moved to California. How can I find out? Often it's a situation where sometimes the patient can contact the lab directly, and that can be something that can happen. Other times, again, that's something where a genetics referral would be appropriate, and we can discuss the VUS and often help to actually have the notification transferred to the current clinician. So these are things that can be done. But I would say the most important thing with a VUS, generally you shouldn't act on it. So you see a VUS in BRCA1, this does not mean you should talk about preventive surgery. You should not. And most people don't, and that's fine. But the point is that we shouldn't manage a VUS the way we would manage a positive result.
Okay, good to understand the history behind it and what we can do moving forward. And then you mentioned earlier hormone therapy. So I wanted to make sure we had time to ask about that. So in someone who has a family history, let's say, of breast cancer, what are your thoughts about hormone therapy for menopausal symptoms or combined oral contraceptives for birth control?
So again, this is a great conversation. We are touching on so many timely and controversial things. It's a privilege to talk to you about all of them. Not that I know all the answers, but I think they're really important. So again, to get a little bit into history, and forgive me if I go on too long, but I think back in, I would say back in the last century, hormone replacement therapy after menopause was incredibly widely used. Ever since the 1960s, it was very widely used. And then when the Women's Health Initiative clinical trials came around and were published in the early 2000s, there was really a 180-degree switch of people saying, take everyone off the hormones because they cause breast cancer. And that was largely due to one of the two randomized trials, the one of estrogen plus progesterone hormone replacement therapy, menopausal hormone therapy in women after natural menopause. And that trial on longer follow-up has indeed shown an increase in breast cancer risk, though not an increase in breast cancer mortality. But so that's the history there. Interestingly, the other clinical trial done in WHI was among women who'd had their uterus removed for whatever reason, and they were given estrogen only. And in that trial, very clearly, it has been shown that the estrogen has not caused breast cancer risk. However, there is breaking news from the upcoming American Society of Clinical Oncology meeting that it seems to be associated with increased ovarian cancer risk. So stay tuned on that in terms of estrogen only. But so I would say that in general, it's the combined estrogen plus progesterone therapy that we worry about more in terms of breast cancer risk. We think probably it's the progesterone that's contributing more there. What about family history? I think it's tricky. There have been a few studies that have estimated that for women with family cancer history, it's really a question of absolute risk. So the amount that the needle is moved by menopausal hormone therapy, estrogen plus progesterone, is probably not very much for most people. And it sort of depends. If someone's risk is already very high based on family history, maybe you want to be a bit more cautious versus lower. I think the other points to make are that in general, studies have suggested that short-term use, so right after menopause as opposed to 5 or more years after, and maybe only for a few years as opposed to longer than that, so shortest duration, lowest dose, may be okay, depending on sort of the pros and cons. Again, I think this gets into a personality test, right? Of what do people worry about? How bad are their symptoms? Are there other things we can do? And I will say, I think there are increasingly good medications to deal with things like hot flashes that are not hormonal. I think there are good data that vaginal topical estradiol is really fine for pretty much everyone. And that's really important because that deals with the symptom of vaginal atrophy. That's a bad problem for people. So I would just say I would consider those other options for managing symptoms too.
Okay, yeah, thank you for that information. I think it's just so important to not necessarily always say no to our patient when it comes to these risks, but really educate them more about how much their risk increases and kind of guide them to make a decision that's best for them.
I agree.
And then lastly, I wanted to ask you about when we should use tamoxifen, raloxifene, aromatase inhibitors for breast cancer risk reduction.
Excellent question. And again, these are drugs that have very good data behind them in terms of randomized trials and are very much underused. The estimate has been that probably 10% or fewer of women who could benefit from risk-reducing medications actually take them. I always joke that we have a marketing problem in oncology because, the cardiologists can get people on statins, right? I mean, it's the same kind of thing. Really, why can't we get people on chemoprevention? One issue probably is chemoprevention, right? So that's a word that people don't like because it has chemo in it. It sounds like chemotherapy. So again, there's been a move toward calling it risk-reducing medication to kind of brand it a little bit differently. I think it's, again, all about risk benefit. And so basically studies that enrolled people, and there have been many randomized trials now, primarily with tamoxifen, basically said that if your risk, they usually use the Gale model, which is one of the older models. And if your 5-year risk using the Gale model exceeded that of a woman of around 60, then that was a level where it made sense. So it's usually, I believe it's a 5-year risk exceeding 1.7 or something like that, then it's reasonable to do it. I usually, rather than using that model, which I don't love, I usually tend to look more at risk factors like family history, right? So some of these patients where, maybe they have a family history of had multiple affected relatives and they're worried about risk, that might be a good person in whom to think about one of these medications. I think like any medication, you want to think about risk factors and side effects. Most of these drugs are pretty safe. So to take tamoxifen, which is the best studied one, there is a risk of blood clots. It's not very high. Numerically, it's about the same risk as the risk with oral contraceptive pills. So lots of people take oral contraceptives. It's really not very different with tamoxifen. There is a slight increase in the risk of uterine cancer. It's probably a few per 1,000 women who will get a uterine cancer. Nearly always that is in older women, women who haven't had a period for years, and typically they will present with vaginal bleeding. Usually they will then have hysterectomy and be cured, not to make light of it, but just saying that that is what we typically see. So we also worry a little bit about stroke risk, more in women over 65. So I always think sort of if you're thinking about who's the perfect candidate to take this, somebody in her 30s or 40s with a family history that puts her at high risk. You don't want her to be taking it if she's also trying to get pregnant, because that is not something you want to have going on. But let's say she's 38 and she's had her desired family and she wants to do something. That would be a great time to do 5 years of tamoxifen. Raloxifene is an option for women who are postmenopausal. So are aromatase inhibitors. So you wouldn't do that in younger women, but those could happen in people who are postmenopausal. And there are different nuances of those. One other thing that I will say that increasingly we're starting to see used is lower dose tamoxifen. There was an Italian trial called the TAM-01 trial. It's relatively small, but it looked at a dose of tamoxifen of 5 milligrams, so a quarter of the standard dose. And at least in that study of a small number of women, 500 women, people did very well with it and in fact had virtually no side effects and a substantial reduction in their risk. These were mostly women with ductal carcinoma in situ or atypical hyperplasia, but low dose tamoxifen was a good option for them. So I would just think about that, particularly for postmenopausal women, it may work better in them. But if you have someone who really wants to try something but is worried about full dose, low dose could be an option.
It's good to know that the low dose is an option, because I hear the kind of side effects of feeling postmenopausal when you're not can be pretty difficult for some women.
So I will just say in my experience, and it's probably skewed, but in my experience, young women in their 30s and 40s usually do fine. I have a lot of 30-year-olds who don't know they're on it. And I think a lot of it is about how much estrogen is around, right? So I sort of gave that story of a woman, 38, 39, you put her on it until she's, 43, 44, she'll probably have very few symptoms. Her period might be later, but she probably won't care.
Okay.
That's been my experience. I'm oversimplifying a little bit, but that's been what I've seen.
Yeah, no, good to know. And then before we run out of time, are there any advances in breast cancer screening and or genetic testing that you are excited about or find promising?
This field is so exciting. It's so exciting. I've been in it now for 22 years and I'm just having the most exciting time because what we can do for patients just increases, and it's such a privilege to work with patients who are dealing with these questions. And, again, it just gets to be more interesting as we can do more and do better. So I think in terms of where we are with genetics, we now are at the point of doing multiple gene panel testing, usually 80-ish, 90-ish genes, looking for cancer genes. We do sequencing, we do rearrangement testing, we do DNA and RNA testing when indicated. And so those are kind of the cutting edge things we do. I think the things that are right on the margin of being standard are things like polygenic risk score, where we are looking at usually single nucleotide polymorphisms in combination that can help us understand risk for a broader group of the population. So not quite prime time yet, but getting close. That's an interesting new one. I think in terms of screening, again, my radiology colleagues have been encouraging me to think more about contrast-enhanced mammography. Again, I haven't ordered it yet, but probably will soon. So I think that's one that's out there. I think MRI is a great screening tool. It may be that there are ways that we get it to be more useful for more of the population. People are working on non-contrast MRI, which would be nice. And people are working on rapid sequence MRI, which would also be nice. So I think those are things that may trickle down. But to me, those are things that are in the offing and looking promising.
Well, thank you so much for this very enlightening conversation. And what are some important takeaways for breast cancer screening and genetic testing that you'd like to emphasize to our audience?
Well, thank you so much for having me. It's absolutely a privilege. I think In terms of screening, it's mostly about risk assessment and having some sense of what is this person's risk, and should we be thinking differently about making sure she is appropriately screened and not underscreened is sort of the way I would think about it. And there I'm thinking about family history, I'm thinking about women with dense breast tissue, I'm thinking about Black women, all of groups of women who I think might be more at risk for being underscreened. That would be my 2 cents there. And then in terms of genetics, I think family history, take a family history, keep it in mind. If it looks like more than 1 in 8 women in that family have breast cancer, that's something to think about and to refer. I think other cancers in the family, keep those in mind as well. And those would be my main take-home points.
Great. Thank you so much for your time and for
Thank
sharing
you.
your wisdom and experience today, Dr. Kurian.
Thank you so much for having me. It was a privilege.